our next session is called Improving Interoperability, Information Sharing, and Collaboration, Keys to Sustainable Success. And as you all know, we're here to discuss the impact that IT is having on healthcare and on the healthcare ecosystem. And one of the most obvious benefits is the ability to share information, which is now in a format that's digital, which can be more easily shared and with the appropriate stakeholders. However, there's some technology challenges with that when it comes to interoperability and different systems being able to communicate. There are obviously some cultural issues when it comes to breaking down silos and just in how to start to collaborate and shift our mentality of who owns the data and how we should be working together. So that's what this panel is going to be addressing. One thing, there's a lot of new faces here, which is exciting, but for the veterans and for those of you who have been involved with us through our other organization, GTRA, this is meant to be a very interactive experience. You saw that we kicked it off with the roundtable. That's so you get in that mode. So for the next several days, every session up here, be it a presentation or a panel discussion, we want it to be as much interaction as possible. So as we're going through and as I'm moderating this panel, if you have questions, comments, objections, interjections, please raise your hand or shout out, and we'll be happy to include you in the discussion and have you be a part of this process. I'm going to go ahead and introduce everyone briefly and then give them a chance to introduce themselves and their background. To my left is Alyssa Ray, who's the Executive Director and CEO for the Certification Commission for Health Information Technology, or CCHIT, as you may know it. To my right is Jean-Claude Ray, the CEO for the Institute for Health and Economics out of Switzerland. And to my far right is Ali Moderesti, the Director for Electronic Health Records Technology for High Tech LA, the LA Healthcare Plan. And my first question, or the first thing I want to do is have each of you start by just introducing yourselves and help the audience understand the perspective from which you're addressing and approaching this topic.
So I get the privilege of starting. Thank you. Thank you, Param. Thank you, all of you, for spending a Sunday afternoon. I'm a local gal. I just came from up the street, but what a nice way to spend a Sunday afternoon visiting and learning with other people who are interested in the stuff that my family doesn't understand what I do. Probably many of you have the same thing. So I work at CCHIT, the Certification Commission for Health IT. I've been there since we were founded, 2005, 2006, and got started. That's for those of you who are not as familiar, we're a nonprofit organization. Our mission stayed the same through the years, and that's to facilitate the adoption of health IT. And sure, we started with EHRs, that's the first part of that, but we also don't confine that mission. We look at health information exchange too as part of that, right? And we've actually seen the readiness of that, and as it relates to interoperability, evolve a whole lot over the short tenure of our organization. So it's a pleasure to be at this panel here talking today. Just a little bit more about the organization. We were started back, as I said, 2005, 2006, by another little startup company called ONC back then, remember? Remember when they were just getting going and had a very small budget? And they created the first strategic plan for health IT. And part of that was talking about harmonizing standards, right? And they viewed certification as an important mechanism that could help drive those standards into commercially available products in the marketplace. We had a contract to work on that. So a lot of the things that are happening with certification now, we're pleased that we helped invent or pioneer. Clearly, when ARA and the high-tech incentives, you got $30 billion, that's a secret sauce that we were all waiting for to really jumpstart interoperability, adoption of health IT and EHRs. So much happened there, and we've evolved with that, and we continue to participate in the ONC certifications. We're one of the organizations that do that. We're the only nonprofit, the only one solely dedicated to healthcare, but that's really important work. We're doing some other work now that I hope to get to comment on a little bit more. I think it's relevant to this discussion. Will come out in our discussion around HIEs and compliance testing to try to get to plug and play with that. We have some partners, the Healthy Way organization that used to be, actually they're spun off from ONC. Healthy Way is the new nonprofit organization that's the keeper of the eHealth Exchange, the operational company there, and also the state of New York and a number of other states have come together in a partnership to really help providers out getting towards plug and play. And I'd like to be able to talk about that a little bit more. But then I guess the other comment I'd make before I hand it off, in terms of just interoperability, I was, there was a big conference this last winter in New Orleans around health IT. I bet a lot of you were there. And a gentleman that I view as a mentor and look at a lot in terms of interoperability, I think many people consider Wes Rischel kind of the founder of health IT and a lot of the standards. He started his talk by saying, you know, I've been in this a long time, 20-something years, but, I still haven't seen a lot of interoperability yet. And I think we're going to talk about that here today, but I think there are a lot of reasons why we should all be very, very encouraged. Some really encouraging things that are beginning to happen now so that Wes and all of us may actually begin to live some interoperability in our careers now. So let me hand it off. Thanks for that start.
Thank you. Jean-Claude?
Yes, good afternoon. I do think also you're pretty courageous to come here on Sunday afternoon, especially in a sunny area. We've been busy with IT and IT-related field since many years also in Switzerland. Even so, we, as the joke goes, need about 10 years before we follow what has been developed in the US. It's about the accepted delay that Europe adapt what you're doing. Not all of it so, because sometimes it precedes it, and sometimes, like the health card that was introduced a lot of time. As a fact, a little after 96, when the Swiss people accepted the complete health coverage for everybody, did it do on this, and we worked on the project. We also had to introduce hospital-based system because we moved on to new financing systems for hospitals, and then new financing systems for nursing homes and for home care. And all that was based on IT or IT aspect, and central one being security, being the security of data, and being, of course, a number of subjects we're going to talk in a minute, like silos, clouds also, and other subjects. So most of the examples I'm going to use are either from Europe or from my country, Switzerland. But most of my training on all those subjects was before starting a project that I would spend 2 or 3 months in the US finding out how you guys are trying to do it. So can it be adaptable to Europe? Thank you.
Great. And Ellie?
Thank you, and good afternoon, everyone. I want to kind of give a background about my organization, LA Care Health Plan, so we can put things in context. LA Care caters to Medicaid or Medi-Cal population in Los Angeles County. And we have about over 1 million members. And we've recently, our state asked us to participate in the dual programs for Medicare and Medi-Cal, and we're adding another 250,000 members to our pool. And I work in the HIT department, Health IT department, and we're fortunate to have a leadership that embraces information technology, and mainly for the purpose of improving access to care and improving healthcare overall. We've adopted the triple aim, I guess, principles and framework, and the triple aim, for those that are not familiar, are the basically excellent patient experience or members experience in some cases, and improving population management, as well as efficiency and effective of cost of care. So our mission is along those lines, and we've also participated in the regional extension grant back in 2010, and we were awarded a grant to become a regional extension center to helping physicians, or 3,000 physicians specifically in LA County, to adopt EHR and achieve meaningful use. And we've been very successful with that mission. We've also participating in health center control network grants, helping community clinics with achieving meaningful use of stage 2. We work very closely with County of Los Angeles Department of Health Services, and we have a lot of patients and members that use those facilities. So we have a very tight relationship with county. They have 4 hospitals and 26 clinics, 44 sites, and 5,000 physicians. Back in 2010, we started an effort towards establishing an HIE, which I'm pleased to announce that it's going to go live or be launched in July of this year. So that's kind of a background on our.
Great, thank you. And we're going to go ahead and just jump right in here. Before we start talking about interoperability and those challenges, I want to first talk about getting to that point. And obviously, that first starts with creating a culture and an organization that's looking to collaborate, looking to share information. And a lot of this, obviously, is a cultural and mental shift from the part of the organization. So I'm wondering, from a people and cultural perspective, what do you think the biggest barriers are to information sharing, aside from interoperability? We'll get to that. But what are some of the other challenges that groups are facing and barriers when it comes to sharing information? Sure.
Well, you have to mention.
Make sure you talk in the.
Oh, sorry. Well, first of all, you have to talk about people, talking about their training, where they come from. You're not going to talk the same language to a physician that you are to director of nursing homes and so on. So this is the first things qualifies, which is language and culture. Language, I'm not going to talk about it. We do have 4 national languages, and we've got to communicate with everybody in 4 different languages. Even so, our country is about, 50 or 100 times smaller than yours? But I want to insist about culture. In culture to all level. I mean, you get the culture, like if we want to talk and convince the German-speaking population of our country, we've got to look to Germany because they read German newspapers. So if we speak to them about things that we read in Le Monde or something, they haven't got a clue what we're talking about. So you have to take culture as a real way of influencing a person's life from birth to death. I'll stop on that.
Yeah, that's a good point. Sure.
So I'll add a couple, and I guess the first was the roundtable I was sitting at a little bit while ago. I see some of the folks out there. We talked about the interesting dynamic between sort of the tension, and Jean-Claude, this building on what you say with people. IT folks are often taking a very standardized or engineering approach, right? Most of my colleagues know where I'm going to say here. And when I think about different EHR companies that we're aware of and all, some of them actually get sort of criticized for having, if you want to say, a very rigid approach to leading their customers through an implementation. And, it's not, they're sort of paternalistic. There's discussion about that. But then if you think about what you need for success, you need a set of standardization, right? You really need a standardized approach. So you've got the culture of engineering and a standardized approach, and here's the workflow that our HR is often optimized to. You need to come together and sometimes sort of humanize that with the clinicians, right? Clinicians, there's a lot of art to medicine still, and don't tell your nurses or your doctors that you must do it this way. So there's an inherent kind of tension just in a systems workflow. You need that, but trying to find that culture. So I think that's one thing. That's a softer sort of component, I guess. But then there's also just the business case, right? And just it's often expensive to find ways to customize HIEs or EHRs to talk to each other. And frankly, the financial incentives have not been there to share data with your competitor up the street. I think we're all sort of awakening to that may be changing with some of the things that are coming down the road with health reform. But so there's, from my perspective, there's sort of 2. There's sort of the internal, softer implementation piece, but then, of course, the business case has to drive it as well.
Yeah. I think the competition piece you mentioned is important because now with new models coming down, you're going from a perspective of that's my competitor to I don't care what you think, you have to work with them.
I need them.
Yeah,
Right.
yeah, I think that's a big piece of it. So to that point, that's kind of talking about, you both mentioned kind of siloed, essentially we're talking about silos here. So I think in general, when you think about breaking down silos, you need some strong incentives. What are the incentives that we can give organizations to break down silos when it comes to information sharing?
Well, I think at some level, we need policy change, and policy change that comes from at the national level, at the state level. I think compensation models and reimbursement models needs to be reevaluated, and I think that would, if the incentives models and the reimbursements is incentivize the sharing of the data, I think that would help the interoperability aspect of this business.
Yeah, I would go along pretty much the same line, but I'll give you an example. When we introduced the DRGs and ICD-10 some years ago, the problem was that you'll have all the hospitals where the doctors, the physicians were salaried, which is about half of them in the country, followed the rule. I mean, they coded or at least checked the coding. They were done for them by their apprentice, like somebody said stupidly in a political debate recently, because they didn't like it. But 50% the rest of the physicians are on a contract base, because we do have a lot of private for-profit hospitals and private non-for-profit hospitals. And somehow, they don't belong to the building. They belong to 4 or 5 buildings because they're contracting out, and the urologist is going to contract out to different hospitals, and many more hospitals than with, for instance, the internist. And of course, they didn't understand the things, and first of all said, no, we don't want to give our data. Second, we don't know where we put it. Third, and so on and so on. Every possible excuses on that line. Well, finally, the thing was, we worked an instruction saying to hospital directors, renew the contract for the external physicians before the end of the year. Otherwise, you're not going to get any subsidies from the states. Normally, private for-profit clinics do receive subsidies as well. Not as many, not as much. And amazingly, the thing was solved within the 6 next month. They found time to go and talk to the general manager, and okay, it was almost nothing. It was just, get the files into our IT system. So there, the incentive is clear. It's either you set out a directive or legislation if you can, and at the same time, the financial incentive is waiting right back there to hit them if they're too slow to do it.
I think money talks always, doesn't it? Anything to add?
Just similar, I think, the new environment's all about financial incentives influencing coordination of care, right? And Jean-Claude gave an example talking about connecting from acute setting to long-term post-acute care settings, right? Well, that becomes a lot more important when all of a sudden there's potentially penalties for readmissions, right? So you are incentive to share information, and all of this is coming. What we need to do is find ways to make sure that the technical costs of creating the pipes for that don't become part of the problem, but actually facilitate the gains we look to see.
So on that, let's talk about interoperability. Why are there so many problems getting systems to talk? Is it the vendor's fault? Is it the community's fault for not demanding it from the vendors? I guess, what's our take on that?
I think there are multiple issues with interoperability. I think one of the underlying, the way I see it, is that we have a fragmented system that we're trying to build systems, IT systems around it, and that by itself poses a big problem. Yeah, I think you mentioned vendors. I think vendors, not deliberately, but I think their business models is defined by customizing specific interfaces, and that is hard to scale those kind of things, and In today's world, I think we need a faster pace. I think interoperability is happening, but it's the very slow progress, very frustrating. I think ONC, Office of National Coordination, has done a good job in kind of giving a direction and but it's like herding the cats, and so it's going to take time, but there are multiple issues, so I'll let my colleagues talk about the other issues.
Well, I wouldn't accuse too much the vendors, but we are in a different situation that you are in the US. Most of the vendors we have are, of course, vendors. I mean, a good 80% are vendors which are originated from the US. And they have subsidiary companies in Germany, France, Switzerland, and so on. Now, to do that and to be successful at doing that, they've had to adapt and to learn the healthcare system. And so most of them who didn't make it was because they didn't learn enough about it. And therefore, there was no such occasion as to really refine their approach and to tell them, well, don't rush to propose this and that and so on. Let's see first whether it will apply. And we did for the potential victim of vendors, if there were any, we had a lot of contracts to do just that is assist in trying to make a bridge in between the systems. And so that worked. The thing that I want to add too is once the Confederation of States in Switzerland, you know that Switzerland is a confederation of states. The states, which we call the canton, asked us what would be the best system or the available system in the world so far as financing and promoting quality for nursing homes. And we did a study for about 2 years and came out with 3 or 4 potential systems. One of which was a US system, another one was the Quebec system, a Canadian system, and 2 were French and so on. And, but at the same time, we conducted a study among something like 7,000 nursing homes, just asking them, do you have any research project concerning that type of tool? And we found out that 90% of all those nursing homes had some kind of a project. Sometimes it was very little, and most of the time nobody knew about it. It was just conferred to 1 or 2 nurses or one direction and so on. And every single one of those projects had nothing to do with the project developed next door, maybe something like 200 yards away. And so we published that, and it provoked a strong reaction in saying, well, these projects are not going to go anywhere because they're too small, and too small scale, they don't take care of any standard. And so that's how we were able to convince the Confederation of States to use one and only standard. But trying to apply these standards was difficult because we found out then that if you want to use a standard, for instance, for staffing, you better know how many hours a day they work in nursing home A or nursing home B. And of course, every single canton, every single state decided in another way. The Catholic states, for instance, have longer vacations, all right? You've got to integrate it, otherwise comparison is not going to be reasonable. Some work 3 shifts or 2 shifts, where you have to integrate this and so on. So what they did, they created the canton, created an institute and asked us to get busy with it, to do just that, make everything comparable. We got about 5 people working just on that so it will work. So standards are absolutely necessary. And the thing we found was that the fact that it was a Quebec standard did not bother people. The fact that we were sending the data to Quebec to be managed, to be analyzed, to be treated was not a problem. We even turned it into an advantage because there's 5-hour difference in between Quebec and Switzerland. So the data were worked out at night in those 5 hours difference, and next morning we got the results. So we were very surprised at that because we thought it was linked to a nation or linked to a canton to have the data treated on the spot. You know, we don't want those foreigners to understand anything about us. And no, it was so much for standards. They're absolutely necessary.
Yeah, absolutely. Any other comments?
Well, I'd just add on, I mean, yeah, it's about having standards, and I think our federal leadership has moved us along tremendously. We have a lot of national standards for interoperability. I mean, really, we do, and many agreed upon them, and I see a lot of heads nodding. You all are part of this world. But the problem is how we implement them, right? When you try to get real, there's optionality in there. So that's the real, where the rubber meets the road for us, the challenge now. We have great standards for how to send and receive a patient summary, right? We have great standards on how to do a query to look up patient records and see where they are. Again, you know, there's a lot that happens in that implementation, a lot of lemonade, limeade, Coke, Diet Coke, whatever your flavor is that folks have to make. And I think there are some efforts that are happening now to minimize that adoption, optionality. Some of the work we're doing with the New York eHealth Collaborative, they've gotten together beyond just one state, but I think there are 19 or 20 states now that have worked with them. And they have a joint interoperability work group with about 19 vendors that have come. And they're looking at the standards for some of these things I just described that we all know are out there. And they're around the table sort of negotiating that optionality and how they would do the implementation. That's the only way, you know, when you have folks really agreeing at that level, that's the only way where you can, you know, get a cord and have a plug and a socket on each end that match and make things happen in a really cost-effective way. And again, this is happening now. It's just getting momentum. So
Yeah, well, that's actually one of my questions, because when I'm in a research position, so I talk to a lot of different people during the week, and everyone seems to have their favorite standard, given what their organization does. You know, some people like NEEM, some people like, you know, I can go on and on. So how do you get, when you have a lot of different stakeholders, and as these pools of organizations that need to collaborate and share information grow and grow and grow, how do you continue to move that process forward and balance the number of standards with the interests of the stakeholders? What are some ideas, and what have you all seen to move that forward? Sure, anybody, yeah.
Well, we are in this process, as a matter of fact, with the last example I brought up. Because some of the, you know, with people changing in the administration of the cantonal authorities, and it's the cantonal authorities who are mainly paying for nursing homes, so they want to have the data because they want to pay according to the data they get. But the thing is that people get older, and some leave the administration and are replaced by new people. And that system has been working for 18 years. So there's a lot of people who have left the administration, and some administration don't remember how it works and don't remember what to do with it. So we decided last year to start a revival on all this in visiting every single cantonal authorities. We get 26 of them, so it's much easier than for you. To revisit them and to have, and that was the first time, 80 people there sitting around the table. And we promised them that we were not going to talk about financing, but we were talking about IT. You know, what type of IT solution are we bringing? And we came out with a lot of suggestions. For instance, we used to have emails to send the data to some of them because they were not equipped, some of the canton being very small. They were not equipped with anything else. And the first decision that was taken is to say, well, we'll have to create a site, and we did, for every single canton boss, so to speak, and that the IT people will know where it is, and will have the key to go and look at the canton's data. And there's another site per canton where they can look at the other state data so they could compare. So that's an example of how it evolved. And so far, we only met success with those actions because they were really needed. I mean, a lot of people say, well, but we don't understand. I mean, we get this data from this source and then from that source, and sometimes it doesn't look right. And sometimes it was simply because a state servant would have access to the data sent to him by one of his friends by mail, and not keep it up. And all of a sudden, our data was getting wrong. I mean, the data we delivered, and that's creating problems. So this is one example of how do you have standard moving and getting, instead of changing standard, which is a hell of a problem, you can have standards which will move along with your problematic. And you don't need to have a state legislation, new legislation to bring them about.
Yep. Any other comments?
Just make a comment about for the folks that have been involved with the health IT. It took over, I want to say, 15 years for the EDI and claim processing to become standardized, and that was a very specific data sets that had to be processed through the system. So my expectation is that the clinical data will take longer than that to become standardized so we can easily exchange information. I think the standards, there are a lot of standards right now, and again, I think at the national level, I think we're moving in the right direction, kind of pushing everybody going to one standard. I think IHE's organization, nonprofit organization, is doing a great job applying those standards for a specific clinical situation, and so all of those efforts is going to eventually lead us to standardizing interoperability.
So there are good initiatives going on. Ali mentioned IG, integrating the healthcare enterprise. It's been around for a while. Many of you have probably participated in Connectathons. We certainly have and have supported them. And so much progress is made there. They create the IG profiles. Again, many of you are aware of those. The Connectathons, you get a bunch of engineers actually sitting in a room, hashing out code, trying to make something work with one of those profiles. So a lot of really positive things happen there, but that isn't quite far enough, right? Because what happens there, those don't actually, those engineers, what they do that day may or may not get locked down into a commercially available product, right? And then often those products are sold, and again, there's still optionality or need for custom interfaces. When I think of some of the work we're doing with the Interoperability Work Group, New York, and the states there, and Healthy Way, they've taken those IEG profiles, a lot of really good work, and as I said, got committees together, stakeholder committees, around really constraining them a bit more, web services and things like that to really try to get your EHR to talk to an HIE. That's absolutely the kind of stuff you have to have happen in environments in New York, right, where you're trying to have state information exchange happen. As part of our federal strategy now. So really, you have to constrain that optionality. I'm kind of sounding like a broken record, but there are things that are happening, and we can see it's very good where we've built upon current work, collaborations continue, but again, trying to keep the providers at the end in the mind, something that they can understand, keep talking about plug and play, and we can make this a little bit simpler than we have.
Absolutely. We're going to move on now to talk about, we've kind of identified already a lot of the challenges we're facing and some good solutions, but we're going to move on to more outcomes and the future and some additional solutions. Before we do that, are there any questions from the audience? Yes, Martin?
No, we don't hear.
Yeah, we have a mic, Martin. Or just yell.
Thank you. My name is Morten Elbæk Petersen. I'm the CEO of the Danish National eHealth Portal, working a lot with integration and interoperability. Also in Denmark, we have been integrating 110 data sources. My question is to Elisa Ray. Working with the Certification Commission, how do you measure success when it comes to helping sharing information, for instance? How can you look up if the year of 2012 was better than 2011? How do we measure that in US?
That's a great question. And as I said earlier, we haven't made enough progress now, but this initiative we're working on with the states and with the Health Way group right now, we're in a pilot with that right now. There are a set of over 500 use cases, many built on the IHE profiles or the direct protocols, further constrained. We're building a reference implementation, actually a very robust testing site that will be open source that I think really we haven't in this country seen an environment like that. The idea is that the developers will look at these test cases, that they've been socialized and agreed upon by the vendor community and the providers, and actually the policymakers. They'll have this environment to go out and sort of beat on, practice in the course of their development. Then they will come to us, and we can actually verify, right, that they've tested in this environment. Should be red lights and green lights on each of those test cases if they've worked out. Then we believe we can get to plug and play. Now again, we're building this now. It's our grand vision. We're far enough along that there's actually a pilot that's happening right now. So how would we measure success? I think we would look at the number of vendors and provider participants that are able to complete this, and then also the volume of those that actually get on different exchanges, whether the national eHealth exchange or the state networks or regional, smaller networks, or even as we're seeing appear now, there may be more private networks, right? But ultimately, if you think about those basic things about looking up a patient record or being able to exchange a clinical summary, all of those networks can get together and do those things. So that's how we would measure that. And I love your question. Thanks.
Thank you. Can I have one more short question?
Yeah, sure.
Because standard, I don't think that the standards are the only answer. And I'm very impressed coming from abroad, coming to US, because you have such clever IT solutions, but you also have a lot of islands, a lot of silos, a lot of different organizations not that collaborated. Maybe one question also should be, when do you make better status of health? When do solutions make better status of health? When is it needed that you collaborate? When is it needed you use standards? I don't think the answer is to have a standard. You have to find out situations where people's health are getting better because you are exchanging the information.
Yeah.
Do you look up to that in your organization? Or who is taking that kind of job in US to find out when does health get better by exchanging information?
Yeah, that's a great point. I mean, I think one of the biggest things is IT is a means to an end, and it's there to enable the business function or mission, in this case being patient care. So I think that's such a group of IT folks often forget that you don't do IT for IT's sake. You're supporting the business.
And we can learn so much from your success in Denmark,
Yeah.
what you've done. Yeah.
Absolutely. Great. That's actually a great segue. I wanted to take a moment. Ali and I were speaking the other day, a week or two ago, about some of the stuff going on in LA. And to your point about using technology to support specific outcomes, we're talking about some telehealth initiatives that he has going on in a program called eConsult. And there's going to be a lot of potential with telehealth as it relates to what we're talking about. So I was hoping you'd take a moment to just bring us up to speed on some of the things going on there.
Sure. So as part of our effort in terms of improving access to care and as well as improving the patient care, we've participated in some of the grant programs that from UC Davis in Sacramento with respect to telehealth, because we think telehealth has a place in the healthcare. I think especially after 2014 and Accountable Care Act and the additional 20 million people kind of accessing the healthcare system. So I think with it's a kind of a supply and demand situation. I think there's going to be a tremendous pressure on the supply side and on the physician to meet the demand. So we looked at the telehealth and a couple of projects or pilots that we participated in. We're involved with, one of them was basically the wireless devices, a lot of medical wireless devices that these are with patient with chronic diseases or sometimes mental health issues that we've been monitoring. So there's a health center that we provided them with these devices and the communication back to the health center. It's a cloud-based system. I won't get into the technology side of it, but it's basically alerts the health center of if the patient is not taking their medication or their situation is deteriorating, and then they can intervene at the right time. And in the study that we've done, and it's been only a year and a half or 18 months, that they've already shown that they've prevented this attendance, going to the emergency room. So there's kind of some advantage there. We've done some web conferencing in some other settings where this is a community where the healthcare providers are, the primary care providers is also bringing in specialists, in this case therapy specialists, to assist while they're there to do the primary care or to do their visits. They can get some help if there are mental health issues from the specialists remotely. So we're still kind of evaluating the outcome of that experiment. Another one that has been very successful, and we know that it's going to continue after this, is a project that we implemented back in August of 2012. And it's called eConsult. And eConsult is basically a telehealth process where a primary care doctor engages a specialist remotely and discusses the patient condition and seeks information from the specialists. And this program has been very successful in several ways. First of all, it basically addresses the patient issue and it doesn't have to get into this referral process, which can be very cumbersome and delays care for the patient. It has improved the number of no-shows and cancellation at the specialists. Since August of 2012, we've processed 9,000 consult sessions. There are 1,100 physicians on these systems, plus another 1,200 staff members that they provide the supplemental information with the eConsult. So the way it works is basically a web process. The primary care physician initiates the session. It poses a clinical question to the specialists. And that information is transmitted HIPAA compliant. The specialists will get a email notification, and they access with the link that's in the email, they access the information that the provider sent, or the primary care provider sent to the specialist. They view it, and then they have either ask for more information, recommend a treatment, or ask for a face-to-face. And so again, that program has been very successful, and we expect that to continue after the end of this year.
Fantastic. Did we have another question from the audience? Yeah.
Yes. Ali, you had mentioned that it took about 15 years to create the standardization in claims. And then I heard another panel member say, we suspect it will take longer for clinical. What do you, as the panel representatives, think we need to do in order to expedite that process of standardization?
I defer to Elisa.
Well, I think Ali's deferring to me probably because I think we think it's going to take a lot of policy and federal help, right? It's a big enough problem that we could say we need a lot of federal leadership with this. We've had a lot, but it's going to take more.
Yeah, I would just add to that. I think some of these is because we have a fragmented healthcare system, and I think over time we will be able to connect all of these disparate systems, and as well as I think with the policy change, I think that's critical in terms of encouraging and the health centers to share data, and I think we've I think ONC with this the grant and the meaningful use, they've planted the seeds, but it would take time for it to come to fruition.
Anyone in the audience have any? Oh, I'm sorry.
I just said, well said. Thank you.
Anyone in the group have any additional feedback on that? That's a very important one. Yes, please.
Yes, as a physician, some of this makes me shudder. I think that perhaps it's more clear-cut when we have maybe an acute emergency room situation. Someone arrives with a specific type of stroke. We've got a specific MRI finding. You know, even then, I think this gets a little cloudy, but you know, where there can be specific standards. But having practiced medicine my whole life, there are just so many scenarios where whatever is on that algorithm just may not apply to that particular person. And for those that attended the HIMSS conference, I think most of everyone in this room, when the cardiologist gave his keynote saying the robot will be with you, I think we need to bear in mind that there are things we can do with technology and streamlining standards, and then there's things that we need to reserve as being rather sacred between a doctor and a patient. And you know, I'm a doctor speaking, so you can say I have my own agenda, but I think for all of us, when we think of ourselves as patients, there's a point where care has got to be personalized, individualized, and when we have the situation where doctors or nurse practitioners or you know, whatever kind of title you've got for whoever's delivering care, wherever they are, is just going by some algorithm, and the nuances of that patient are not being taken into consideration. We don't have health care anymore. We've just got some mandated system that doesn't, I think, do the right thing. And nowhere in any of these discussions do I ever hear one word being said about how we might reduce the drugs we have people on. So it's all about getting everybody on this drug or that drug. There's not one word being said in any of these meetings, any place, about the terrible concern about how many drugs people are on and what we could do to reduce it.
Certainly. Thank you. Yes, please.
My name's Dick Thompson. I'm with the Quality Health Network out in Grand Junction, Colorado, and we are an HIE amongst other things. The question I have for the panel and for the room is a whole. With the drive towards the digitization of health records, many of the physicians in our area are saying, it's too complex, I want to practice medicine. And more hospital systems are buying the practices, because when they do that, they get out of the hassle of worrying about standards because they are imposed. So I'm wondering if an unintended consequence of the effort may be to drive to more of what I'm going to call integrated delivery systems, very similar to Kaiser. Ali, you really have one with both a payer and a plan in LA. And I wonder, I don't have the answer to this, but it is a concern of ours because we connect 218 disparate organizations out in Western Colorado, but would an unintended consequence being many of the ambulatory care doctors simply say, I give up, my local hospital wants to buy my practice? So I wonder what the panel thinks.
I'll start. So when CCHIT began our work, if you want to say our target was looking at smaller provider practices, 4 to 5 person practice, because those were the ones where adoption was really, really the lowest. And if you think about it, it was because they bore the hugest amount of risk, right? The financial risk to acquire those systems. What if it didn't have the functionality even that it should have had, the basic things you need to do. So we really started gearing our criteria and work around what was the basic functionality and thinking about the smaller practices. As our work evolved, we began looking at different care settings, different provider specialties started coming to us and asking us to evolve that. But if you think about just that time period, the statistics that you cited between 2006 and now, 2010 or so, we've seen a huge set of consolidation and change. There aren't that many smaller practices left. I was looking at some statistics, I believe, from the Medical Group Management Association and some other studies that even in that less than 10-year period, going from self-operated to wholly owned practices, it's like over half now, right? I'm loath to quote exactly because I can't remember exactly, but heads are nodding. So there have been other factors happening. I think the overhead and the challenges with health IT have been part of them, but clearly the whole environment has been very hard for that group to keep that status, that it's easier now to be part of a bigger system or be employed. You don't have to pick which EHR, and if it's not working well that day, you call the IT department. Right? People want to practice medicine. But again, health reform is, I think, driving a lot of that too. Aren't we seeing consolidation at the not just the ambulatory practice level, but right, IDNs and other level? So consolidation is a huge trend in our industry. I could go on and talk about it within the vendor market too, right? And some of that may be good, right? But maybe not so much in the provider side. I'll let my other colleagues.
Yeah, I would just add to that. We've heard those comments about a physician actually being challenged and many that want to give up medicine. But on the other side of the coin, we see the new workforce are coming, new providers are coming. They are eager for technology and they adopt very quickly. As part of our work as a regional extension center, we recognize that, and we actually realize that a lot of providers, they just don't want to touch the EMRs, and that was fine because they had some other plans for their practice. But what we notice is that it requires, especially for small doctor offices, that they don't have the resources that helping somebody coming with experience and helping them with the workflow redesign, with adoption of the technology in their practice, without disrupting the care, and then helping them with the whatever the workflow redesign or re-engineering had to take place in order to adopt that. We saw that with the adoption of the electronic health record, with helping them with compliance reports for meaningful use. We see that in the project for e-consult. So part of that is that the challenge is that you cannot throw the technology at these practices and say, take it. We have to provide the supporting resources to be able to make it successful.
Yes.
I think one more concern that we should have is that as we have fewer independent practices, there's going to be less competition, there's going to be less options for people. It's going to be siloed into very few people having control over what does and doesn't happen. And as much as I respect hospitals and big systems, I'm not sure that what is necessarily in their best interests, historically it's been filling beds. Yes, that may change, but I think a lot of primary care practices would not have elected that as many arthroscopies get done, as many upper GI endoscopies, and so on and so forth, that just clearly aren't indicated, but have been good revenue producers in the past. So I guess as this model changes, maybe that's good, but one of the consequences of all of what you're talking about here today is that the newly trained physicians, although they may be more eager for electronics, are less capable of assessing the whole patient in their entirety. So there's very few doctors now that even know how to use a stethoscope. It's just less relevant in private practice. And we can train ears to assess things like this a whole lot easier and cheaper than we can ever use technology. And it's great to use technology and have it when you need it, but there's no replacement for a child knowing how to write, which is going away now. And you know, we only need to print or type into the computer. And also for a doctor to be able to use a stethoscope. It comes in really handy.
There are potentially unintended consequences of all of our providers adopting so much technology, and I think you've summarized it. And, you know, an analogy is, we've all had the experience, you go out for drinks or dinner with your friends and everybody's staring at their phone the whole time.
Yeah.
You know, I mean, you can take that into the care setting, and I think that's what you're describing, and you've got a, you know, physician staring at a keyboard all the time. There's a lot of nuanced communication, connecting with the patient that helps with the diagnosis and the therapeutic process, and, you know, we may be unintentionally altering that. It could be an unintended consequence.
I think we have time for one more question. And
Yeah, I have a question with interoperability. Are there any solutions, any plans for solutions for the issue in patient, a unique patient ID? I'm working with a lot of different integration projects across within an organization, let alone from organization to organization. But if you look at all of the different systems, all have separate patient, you know, medical record numbers. You're getting in claims. The payer has a different way to identify the patient. There is no NPI. It's a real challenge when you're trying to integrate.
It sure is, absolutely. And, you know, of course, we have this unique situation where Congress prohibited us from creating, under HIPAA, a unique patient identifier from everyone. It's in the law, right? But there are initiatives going on. There's, for instance, things I'm aware of, the Care Connectivity Consortium is some great provider groups, Kaiser, Intermountain, Geisinger, Mayo, at least one more, maybe Cleveland Clinic in that. But they have become sort of they've put a lot of initiative into patient matching research, right? And they are working with the eHealth Exchange. They're sort of their RD group there. So I know there's a lot of research going on there. That's also one of the things that the new, the Commonwealth Alliance, a group of vendors, have said that they intend to do some pioneering work on, and that's just getting started. But that's a really important area that hasn't gotten enough traction, right?
Yeah, it drives me crazy every day when I'm trying to do it.
Very practical, very
You know.
real. Mm-hmm.
And I
Here.
think in closing, I think that's definitely from my perspective, risk management security is overlooked too often in these discussions. So although it's very frustrating, in a way, sometimes I think we don't do our due diligence and thinking of of what could happen at a worst case scenario, and we rush. So hopefully, to your point, they're working on it,
Yeah.
and it will not be something that we're just going to forget about, right?
Well, no, either they rush or they make assumptions and they put people together that don't belong together.
Exactly, yeah. Well, great. Well, I'm sorry we're out of time, as always. There's never enough time for these discussions. But panelists, thank you very much. This was a great discussion.